Let me just minimize this. Okay, so this is your first case. So this is a case with a patient who has come with the left lower quadrant pain.
Sure.
So
Okay, so I'm presented with a CT of the abdomen and pelvis. I'm just going to scroll through the images.
also this patient has raised inflammatory markers.
Sure. So this CT has been performed with contrast. I'm just reviewing the images. So on my initial scroll, I note that there is stranding within the left iliac fossa. And this is centered upon the distal descending colon. Just looking to see whether I can see any evidence of diverticulitis within the left iliac fossa. So there are several diverticula within the sigmoid colon. Sorry, the scrolling's a little bit lagging. And arising from the distal descending colon, there does appear to be a small gas-filled diverticula with surrounding stranding surrounding it. So I think these appearances do represent acute descending colon diverticulitis. I don't see any evidence of perforation. There's no free gas. I'm just reviewing the remainder of the images to see if I can see any other abnormality. Just checking the liver to see if I can see any evidence of liver abscess. I don't see any evidence of a liver abscess. There is also some stranding within the subcutaneous tissues overlying the left iliac, overlying the left anterior abdominal wall, but I see that's on the other side, so I don't think that's significant. So in summary, I think that this CT demonstrates features consistent with acute uncomplicated descending colon diverticulitis with no evidence of perforation and no other complications such as liver abscess. I would call the clinical team and inform them of these findings and recommend a general surgical review in the first place.
Okay, so the general surgery reviewed and they gave the patient uh, has treated the patient with antibiotics and uh, he went back, but he is later on he's come with some non-specific symptoms after some time, and then they did a repeat CT. So let me just share the repeat CT. Okay, second. Yeah, so this is the repeat CT is done after a couple of months.
Sure. Okay. Do I need to request control again or?
Yeah, you can start scrolling.
Sure. Okay. So I'm presented with a repeat CT abdomen and pelvis in the same patient who is represented 2 months later. I'm just going to scroll through the images from top to bottom. So just reviewing the same region in the left iliac fossa, there are again several uncomplicated diverticula, and the stranding that I saw previously has improved compared to previously. I'm just reviewing the bowel wall as it does, just checking to see whether there's any evidence of mural thickening. There is still some residual stranding surrounding the bowel wall, and the bowel wall does look thick-walled in this region. I can't see any surrounding lymph nodes within the region. Given there is some mild mural thickening and some residual stranding in the region, and the patient has ongoing symptoms, I think an underlying lesion at this territory cannot be excluded. And I would, in the first instance, inform the clinical team of these findings and recommend direct visualization with colonoscopy. I'm just reviewing the remainder of the bowel to see if I can see any other anything else anywhere else. But I haven't seen anything anywhere else. So yeah, in summary, I think that there is persistent mural thickening of the descending distal descending colon with mild stranding, and an underlying lesion can't be excluded at this site. There's no evidence of enlarged lymph nodes in surrounding this part of the colon, but I would recommend direct visualization with colonoscopy in the first instance to exclude an underlying mass lesion.
Okay. We'll go to the next case. Yeah.
Okay. So I'm presented with a contrast-enhanced CT of the abdomen and pelvis. Just going to scroll through the images.
Okay. So this patient he has some pain in the abdomen and some vomiting.
Sure. So on initial scrolling through, I've noticed a rounded calcific structure within the pylorus of the stomach. I'm just going to scroll back up to it. The stomach does not appear distended at this point in time with fluid. And I'm just reviewing the gallbladder because there does appear to be gas within the gallbladder, which is thick-walled. And there appears to be a communication between the pylorus/proximal duodenum to the gallbladder, with gas within the gallbladder. So I think these appearances are most consistent with Bouveret syndrome, which is where you get a fistulous communication between the duodenum and the gallbladder, and the gallstone passes into this pylorus or the duodenum and can potentially cause obstruction. In this particular case, I don't think there's evidence of obstruction at this point in time, but the gallstone would need to be removed to prevent further obstruction from occurring. So I'd inform the clinical team urgently and recommend a general surgical review as the patient will likely require surgical management.
Okay. We'll go to the next case. So this patient, he has right-sided chest pain and dry cough.
Right-sided chest pain and a dry cough. Okay. So I'm presented with a frontal chest radiograph in a skeletally mature patient, and the patient has presented with a dry cough. Within the right midzone, there is a thick-walled cavitating lesion with surrounding airspace opacification. There's no associated pleural effusion, no underlying bony rib erosion that I can see, and no bony lesion or deposit that I can see within the visualized bones. This is a solitary lesion. I can't see any other lesions anywhere else. My main differential for this in a patient who is presented with a dry cough with no history of infective symptoms would be, I think my primary differential would include a cavitating malignant lesion. This may be a primary lesion, such as a primary lung cancer, and the most likely subtype would be a squamous cell carcinoma. Alternatively, it could be a secondary single metastatic deposit arising from most likely a head and neck cancer, given its cavitating. If the patient did have infective symptoms, then it could represent a lung abscess. But I haven't been provided with any information, but I would correlate with clinical history and inflammatory markers to check if there's any evidence of the patient being septic. Alternatively, other less likely differentials for a solitary lesion, I think, would include a rheumatoid nodule or a cavitating lesion secondary to GPA. But again, these would be much less likely given it's solitary. So in the first instance, I would recommend a CT chest for further characterization of this lesion, would inform the clinical team and recommend referral to the respiratory multidisciplinary meeting for further workup of the patient. And if CT suggests a malignant lesion, then a biopsy would be required, which could be discussed at the MDT. Yeah.
Okay, where do you think the lesion is located?
So I think it's within the lung. Just trying to, given it's got it looks like it's got gas within it. So I think it's within the lung.
Can you be a little bit more specific?
So given within the lung, I think I can see it outlining the horizontal fissure superiorly. So I think likely within the right middle lobe.
Why do you say right middle lobe? Why not the
Um,
lower lobe? Is there any specific reason why you say it's a middle lobe lesion?
because I think the right middle lobe abuts the horizontal fissure. So I think given it, I can see the outline of the horizontal fissure. I think this is most likely within the right middle lobe.
Okay, what about the cardiac margins?
So the right heart border is intact, which I guess points away from it being in the right middle lobe. If it was in the right middle lobe, you would probably expect the right heart border to be obscured. So given that, that may suggest that it's actually within the right lower lobe.
Okay, you can just have a look at this. This is the
Okay.
same page.
So I'm presented with a contrast enhanced CT of the chest. I'm just scrolling through the images. So just within the right lung, there is a dense region of airspace pacification with associated ground glass opacification as well. There is some mild interlobular septal thickening within this region. I'm not seeing a definite cavitating lesion that I saw on the chest radiograph. I can't see any air bronchograms through the dense region of opacification. So I'm just trying to have a look and see. I can't see anything within the left lung. And I think it is located within the right middle lobe predominantly, although I would review in three planes as well to check on sagittal and coronal. So in summary, there's dense airspace pacification within the right, predominantly within the right middle lobe with associated ground glass opacification. My main differentials for this appearance, I think, would include infection. I can't see a specific mass lesion or a cavitating lesion that I could see on the chest radiograph. So I think infection would probably be at the top of the differential. I'd correlate with the clinical history of the patient as well as the inflammatory markers. Was any clinical history provided? Can't remember if you told me at the beginning.
Yeah, as I mentioned, it was a right chest pain and dry cough.
Sure.
Also, the patient had a known case of CA breast some time ago.
CA breast, okay. Um, so I think infection is within the differential, but given there is a focal dense region of airspace opacification with no bronchograms, an underlying mass lesion can't be excluded on this study. So again, I would recommend, I think in the first instance, referral to the lung MDT for further discussion. regarding whether this may require biopsy. I can't see any associated lymph nodes within the mediastinum on the lung windows, but I would also check on the soft tissue windows.
Okay, we'll go to the next case.
Sure.
Yeah, let me just, yeah, you can start with this.
Okay.
Yeah.
So I'm presented with an MRI of the brain with axial T2 sequences. Just going to scroll through the images. So on initial scroll through, there is quite symmetrical and homogeneous high T2 signal within bilateral white matter, the deep white matter of both lobes of the brain. This is symmetrical in nature, only involves the deep white matter and spares the U fibers, and there's no cortical involvement. It doesn't demonstrate any mass effect, and the ventricles are preserved, and there's no sulcal effacement either. I'm just reviewing the rest of the brain. So I think that's the main abnormality and main finding that I've seen on these images. My main differential for this, bilateral symmetrical high T2 signal within the deep white matter of the brain. I would obviously look at the other sequences in the first instance. Am I able to, or would you like me to give a differential based on just the T2?
Oh no, which sequence could you just if you tell me the sequence, I will show it to you.
So in the first instance, I would probably check the flare sequences and then probably the DWI.
Okay, let me show you flare. Yeah.
So I think the flare has similar appearances with high signal within a similar distribution to that described on the T2. So I'd also want to check the diffusion images, so DWI and ADC if available.
Yeah, sure. So this is the DWI.
Thank you. So there's high signal on the DWI. I'd want to check that this is a low signal on the ADC.
Yeah. I'll show you the ADC also.
So I can't see any definite low signal on the ADC to suggest restricted diffusion. So I don't think these lesions are restricting diffusion. And if we have any pre and post contrast imaging, T1 pre and post contrast, that would be what I'd also like to check. If not, I can provide a differential based on what we've seen.
Yeah, we don't have contrast imaging.
Okay. So in summary, there are bilateral symmetrical high T2 and high flare signal abnormality within the deep white matter, which spares the U fibers and spares the gray matter, and doesn't demonstrate any mass effect. I think my main differential for these appearances, in the first instance, I would want to know if the patient has any prior history of any neurological disorders such as demyelination. If they did have any prior neurological history, such as a demyelinating disorder, this could represent demyelination. I'd also want to check if the patient's immunocompromised as a HIV.
Okay, let me just tell you the history. The patient is a known case of COPD, and he's desaturating. He requires oxygen.
requires
So yeah,
Okay. And there's no history of immunocompromise in the patient, such as HIV.
Oh, no.
Okay. So my first thought when I initially saw the scan was, could this be a HIV encephalopathy given the symmetrical changes? I would recommend a HIV test in the first instance. Other differentials, if given the patient has COPD, I'm just thinking.
Okay, let me just take over.
Sure.
I'll just show you. I think we have just enough time for feedback now.
Sure.
So let me just go back to the first case. Can you just give me the control? Yeah, stop sharing. Yeah.
Yeah, I've
So,
stopped.
yeah, sure. Let me go back to the cases. So the first case I showed you was this one. Yeah, so this case you did extremely well. Uh, I think you did really well. But let me just add to what you had already mentioned. The patient, as I mentioned, was having a raised inflammatory markers and had come with pain. And you mentioned anyone would have thought that this is diverticular disease initially, but you should always remember that you can see this fat stranding over here. This is fat stranding surrounding the descending colon, which is inflammatory, and also the patient has some diverticular disease. But what you see here is a diffuse, dense, soft tissue area, which is within the descending colon, and it's circumferentially thickening the descending colon. So this should, you should always keep in mind that this could be a malignancy. So keep in mind that always when you're mentioning the report, just uh, say that however malignancy cannot be ruled out, suggested follow-up after the treatment. So it's important that you follow this up and not just send the patient back home with antibiotics thinking it's just diverticulitis. So when you see the follow-up scan, you did very well. You said, yeah, there is the inflammation has gone up. Luckily, this patient came back with some non-specific symptoms, and we did suggest a follow-up, and the patients did not have any fat stranding. But you see there is circumferential soft tissue enhancing thickening of the descending colon. So this was actually a malignancy of the descending colon, and which was mimicking diverticular disease. So you need to remember that this colonic malignancies can mimic diverticular disease, and when you see dense soft tissue, if it's diverticular disease, usually it will not have that much enhancement and will not be dense like the malignancy. So this is a case of descending colonic malignancy. You see this enhancement, you see the thickening, and you see the fat stranding is not there anymore. So it is definitely malignancy. And they went through colonoscopy, as you already mentioned. As you mentioned, they were subjected to colonoscopy, and it turned out to be malignant. Okay. We'll go to the next case. The next case also you did really well. The patient had a prior ultrasound. Let me see if I can show you the ultrasound. Yeah. So, yeah. So yeah, this is the ultrasound of the patient. You see that there is gallbladder edema, and patient had GB stone. And then the patient has, as you mentioned, the patient there is there's a curvilinear density which is seen in the region of the duodenum, which is nothing but which is causing obstruction to the stomach, the gastric outlet, and the duodenum. But there is not significant stomach dilatation. You mentioned all these, and this is nothing but Bouveret syndrome. You also mentioned there is gas within the gallbladder, which is an important sign, which you very well picked up. And that is suggestive of a choledochoduodenal fistula. So this is a gallstone which has gone into the pylorus into the duodenum, and which is causing not significant but some obstruction, and that's why the patient has some symptoms. Also, when such cases, you need to look at the lung window, which you didn't mention. You should say in exam, even if they don't show you, always mention that I would like to look at the lung window, because these patients have a risk of aspiration. You can see there are some densities over here. So they're always at risk of aspiration. So always look at the lung window whenever you are there's any for any case of GI case, you always say that you would like to look at the lung and bone window. And if the examiner doesn't want to show you, he'll be like, yeah, there's nothing in that. So this is a case of Bouveret syndrome, which is causing which is a gallbladder stone in the first part of duodenum, causing some obstruction because of a choledochoduodenal fistula. So let's go to the next case. The next case was, yeah, this one. This one, yeah. You in the initial chest X-ray, you did really well. You mentioned, I think you mentioned all the findings. There is ill-defined lesion in the right middle lobe. As you mentioned, it is limited by the horizontal fissure, so it's most likely in the middle lobe. And also, you're not seeing the cardiac margins well, but there is some rotation, so it's difficult to use that. But usually in right middle lobe lesions, we don't see the cardiac margins well. And also this central lucent area, which could represent a cavitary lesion, but usually mass lesions are more well defined, so you can always consider consolidation in this case. So there is the differentials of consolidation in the right middle lobe or a cavitary mass in the right middle lobe. And also I mentioned it's a breast cancer case, so you can always suggest metastasis, but so you suggest it's more ill-defined. So consolidation would be higher on the differentials rather than mass and metastasis, but those can be considered on a chest X-ray. You would say that, and you suggest a CT, as you correctly mentioned. In the CT, what we are seeing here is there is dense consolidation. There is no cavitation which was seen. That's just it looks like there is some cavitation, but there is no actual cavitation. But there is dense consolidation involving the right middle lobe. Also, you're not seeing any uh, air bronchograms. So, but always mention there is no endobronchial lesion, which you didn't mention. You should always see and mention that I'm not seeing any obvious endobronchial lesion which is causing this symptoms. There is no obvious mass lesion. This is definitely consolidation. But you have to mention that you will follow this up. You mentioned biopsy. Biopsy is not, we don't generally do a biopsy with a patient with dry cough. And if you're seeing this picture, you don't do a biopsy initially. Only if it is not resolving after antibiotics on the follow-up CT, you do a biopsy. So that is not correct. But otherwise, this is just consolidation. And we'll go to the last case. The last case, I showed you the T2. You were correct about that. There are periventricular confluent white matter changes. You're seeing these changes. This is a T2 weighted image. They are diffuse periventricular white matter confluent white matter changes. And then you mentioned that you wanted to see the flare, and you see the similar findings on the flare images. And then you mentioned that, then I was surprised because you mentioned that you want to look at diffusion, and you picked up the abnormality on the diffusion weighted images. That is, you see this areas of diffusion restriction on the DWI sequence. But when you saw the ADC sequence, you're seeing these areas. You see these areas. These are nothing but areas of diffusion restriction. All these are dark on ADC. If you see this, so if you see, yeah, if you see the not able to get this, but you see this, this is
Okay,
not
yeah. Okay, I can
restriction.
see it now. Yeah. Okay, sure. Yeah.
I think you need to adjust the window. Even the exam, maybe you can ask the examiner that I would like to change the window and see. So sometimes they won't give you the correct window, and you need to say, okay, if it's a stroke case, I would like to see stroke window. You need to say that, and you need to see change the window and see. And there are areas of diffusion restriction, and with the history of, I mean, you mentioned HIV and all that, but I think with a history of desaturation, and the patient is a known case of COPD and desaturation, of course, HIE should be top on your differential. So this is nothing but hypoxic ischemic changes in the brain. which is bilateral confluent periventricular white matter area, T2 signal changes with diffusion restriction. So this case was okay, but the rest of the cases you did really well.
Thank you very much.
Okay, so we can go to the next candidate now.
Hi, Doctor. I'm here.
Yeah, so I'll go to the next case. Yeah, this is your next case.
Okay,
So
unprovided. Yeah.
okay, the patient has some swelling in the leg, yeah, erythema and swelling. Yeah.
Okay, so I'm presented with distal tibia fibula radiographs, ankle radiograph frontal projection in skeletally mature patient who has presented with leg swelling and erythema. Taking a moment to look through, I see normal bone mineralization. There is no ankle subluxation, no fracture line identified. Otherwise, I don't see any, the thala dome is intact. I don't see any osteochondral defect. Rest of the bones are unremarkable as well. I do appreciate that there is soft tissue swelling at the medial aspect of the lower leg region. There are no calcifications within or gas shadows within. I would like to review the orthogonal view as well to check if there's any other abnormality.
Okay.
So assessing the orthogonal view, looking through, there is effacement of the Kegel's fat pad. Otherwise, I'm looking through the bones carefully. I don't see any fractures of the anterior process of calcaneus or talar neck. There is no hidden fibula sign. No fractures identified still. So with the effacement of the Kegel's fat pad, I don't see any soft tissue calcifications or air. This could represent a soft tissue inflammatory process or a lesion within a soft tissue lesion around the ankle, possibly at the posteromedial aspect, which needs to be assessed further with ultrasound. I believe that that would be helpful to further assess. I would correlate with any elevated septic parameters as well to look for any collection at this region.
Yeah, the sonographer is not available right now, so they just went ahead and did an MRI.
Okay. I'll just request control.
Yeah, sure. So any particular sequence you would like to start with? Okay, you can start with this one, yeah.
Okay, doctor.
Are you able to scroll?
I can't.
Okay, can you just request again? Or maybe if you want, I'll scroll, but can you request control?
Okay, I'll do it again. It says you have already given.
Okay, yes, you're able to scroll.
Okay, I'll look through the MRI images provided. So I could appreciate that in this sequence, there is some, this is a T2 fat saturated sequence showing some hyperintensities in the thala dome region. There is some hyperintensities at the posterior subtalar joint as well. I don't see similar signal abnormalities in the distal tibia or fibula. There is no significant joint effusion noted. At the posterior ankle, I don't see any collection or so. In my routine practice, I've reviewed the rest of the sequences as well. There is no ankle subluxation identified, but the signal changes at the thala dome and the posterior subtalar joint this could represent an infective process. Shall I review any other sequences, doctor?
Yeah, let me show you the T1.
Mhm.
Okay, this is the T1 sequence.
Reviewing the T1 sequence, coronal section. Mild T1 hypointensity at the taladome region. Otherwise, the distal tibial fibular syndesmosis is like not interrupted. I don't appreciate any other areas of signal abnormality. The tala dome itself, I don't appreciate osteochondral defect. At this point of time, thinking of possible an infective process at this region, but I don't see a fracture line or so. So overall process, I believe that this could represent an infective process. I would look through the rest of the images as well with the joint swelling and the signal changes at the taladome and posterior subtalar joint, which needs to be followed up. An orthopedic review would be helpful, and patient needs to be followed up. And
Let me just show you the T2 axials. One
okay,
second.
doctor. Mhm.
Okay. Yeah, these are the fat suppressed images, axial sections. You can just scroll through it.
Okay. So scrolling through the T2 fat saturated sequence, I could appreciate that the signal changes within the calcaneus, which is hyper
Just
intense.
yeah, just 1 second. I'll show you the other sequence also.
Okay.
Yeah. Yeah, you can see this one is better, yeah.
Okay.
The patient has a swollen leg, like it's erythematous and swollen, and also some prior history of trauma. So he had a minor trauma. He also had trauma, yeah.
Okay. So reviewing this sequence, I could appreciate the signal abnormalities at the calcaneus, as well as the talus, as I mentioned earlier, with some edematous changes in the surrounding soft tissues. So with the history of previous trauma, I would be suspecting some infective process at this location, which needs to be treated with antibiotics, needs to be referred to the orthopedic team for follow-up.
Okay.
Yeah.
Yeah, continue.
No, I would review the rest of the images as well to just make sure that I'm not missing an intraosseous abscess. If there is any ADC DWI, I would review that as well. At this point of time, I'm seeing signal changes. I don't see a definite loculated lesion to suggest an intraosseous abscess in this location.
Okay, let's go to the next case.
Okay.
Yeah, you can start with the topogram. He has a past history of right inguinal hernia, and he comes
Okay.
with the vomiting and constipation right now.
Okay. I'm reviewing the topogram for this patient who has had a previous right inguinal hernia, who has come with vomiting. Reviewing this topogram image, I could appreciate that there are dilated loops of small bowel at the upper abdomen. There is no dilatation of the large bowels noted. I don't see any gross pneumoperitoneum or pneumatosis intestinalis. I don't see any air fluid levels. Assessing the for any calcifications, I don't see any calcifications. I don't see any bowel gas extending to the hernial orifices in this topogram image. And reviewing the bony skeleton, I don't see any suspicious destructive osseous lesion. Visualized lung bases are unremarkable. So can I see the CT image, doctor?
Yeah, you can go ahead. You can see the CT image.
Okay.
Let me just show you 1 second.
Okay.
Yeah.
So I'm provided with the CT image for this patient, taking a moment to look through. I could appreciate that there are multiple loops of dilated small bowels, as mentioned earlier, with no dilatation of the large bowel noted. There are air fluid levels within. There is presence of right inguinal hernia. I'm just going to assess the gallbladder quickly. Gallbladder is contracted with some suspicious air within. So I would look through the rest of the CT images as well. Coming lower down. So I could appreciate that there is a rounded calcified structure in the pelvis, and that is within the small bowel loops. Yes, it is separate from the large bowel. And I could see lower down the hernia on the right side. So I don't see any pneumatosis intestinalis in this soft tissue window. I don't see any gross pneumoperitoneum. So in this patient who has had a previous right inguinal hernia, I would just look through the vasculature as well in my routine practice, just to make sure that it is all, I don't see any thrombosis within the superior mesenteric artery. So overall findings, small bowel dilatation with a calculus in the pelvis raises suspicion of a gallstone ileus actually. And I could also see that the gallbladder was contracted with air within. This could represent a cholecystoenteric fistula with a stone which has been translocated to the pelvis region. This would represent a gallstone ileus. In concurrent finding of a right inguinal hernia as well. So this finding is an emergency finding. I would pick up the phone, inform the findings to the general surgical team because they would go in for an laparotomy.
Okay. Let's go to the next case.
Okay.
Yeah, so yeah, you can take this one.
Okay. So I'm reviewing MRI, T2 weighted images, axial sections. Taking a moment to look through the image. In the first instance, I don't see any ascites. I could see some asymmetry in the left kidney in comparison to the right.
You can ignore that.
Okay, so I don't see any dilated loops of bowel. I don't see any pleural effusion, the visualized lung basis. Reviewing the liver, there is a lesion at the segment 4 of the liver, which is hyperintense, which is intermediate in signal with a central scar noted, which shows hyperintensity in the situated sequence. Otherwise, I don't see any multiplicity of this lesion, and the liver margin is preserved. I don't see any perihepatic free fluid or enlarged perihepatic lymph nodes. Rest of the abdomen was unremarkable. So overall findings of this liver lesion, segment 4 liver lesion, with a central T2 hyperintense scar would make me be suspicious of focal nodular hyperplasia, since the central scar is edematous. I would review the rest of the images as well. A differential to this would be any other lesion with a central scar. This could be a hepatocellular carcinoma, but it is less likely because the liver is not cirrhotic. And fibrolamellar carcinoma will show more invasive pictures, and the central scar would not be edematous. It would be hypointense on T2 weighted. I would review the rest of the images as well. Yeah, and I believe that this is a benign lesion, focal nodular hyperplasia. Hepatobiliary review will be helpful.
Okay, so they want the hepatobiliary team asks you, like, is there anything they can do to confirm that it is in fact FNH, and if it's not a cancer? Is there
I would
anything you want to do, or do you
I
want to
would
call him back for a follow-up, or do you want to do anything else to confirm?
I would review the post-contrast images as well to look for any washout seen in the delayed images or in
Let
the
me,
hepatobiliary. Yes, doctor,
yeah,
sorry.
let me
Yeah.
just show it to you.
Mhm.
Yeah, you can go ahead and scroll.
Yes. So scrolling, one moment, I can't scroll. Okay, so I'm reviewing the hepatobiliary phase. There is no signal void within the lesion, suggesting that this is of normal liver tissue content, and this would be in keeping with the focal nodular hyperplasia. There is no void in the hepatobiliary phase noted.
What do you, I mean, I didn't understand that. Could you elaborate? What void are you talking about?
No, there wasn't a void in the hepatobiliary phase. So a suspicious lesion like hepatocellular carcinoma will have a hepatobiliary void. It would appear hypointense. So at this moment, it doesn't have that void. So I'm suspecting. I think that this is a benign lesion, doctor. So focal nodular hyperplasia will have more like a proliferation of normal tissue. So I don't think this appears malignant.
Okay, what would you do now?
Suggests follow up with ultrasound will be helpful. Yeah. I don't think this is invasive at this point of time. Yeah.
Okay, we'll go to the next case.
Okay.
Yeah. I think we don't have time. I'll go to the feedback.
Okay.
Let me go to the feedback. So the case number, the first case, what we saw was this one. So this case, if you see there's a very subtle finding on the X-ray. I showed you the X-ray first, and the patient has history of swelling in the leg and redness, and also history of minor trauma. You see this lucent area over here. Are you able to appreciate it, candidate 2?
Yes. Yes, doctor.
This is the lucent area which is seen on the talus. So this is the only finding which is seen on the X-ray. You see this lucent area on the talus,
Okay.
and you correctly asked. Even if you're in the exam, I know and I understand that it's very difficult at times. It's a very subtle finding, and sometimes you don't see anything in the exam when you're sitting in the exam seat. So you correctly, I mentioned that you want to do a lateral view, and you mentioned the findings. You mentioned the You can see that there is some obliteration of the fat pads, and also you correctly mentioned that you would do an ultrasound. That's the first thing to do. But right now the ultrasound wasn't available, so they did an MRI. So in the MRI, you're seeing this. Are you able to see this hyperintense area? So this is an ulceration. The patient has swelling and redness. He also has ulceration. So there is ulceration and some fluid connection. We in the T2 weighted images. We do a contrast, and this is the post contrast image where you don't see any enhancement. You're not seeing any enhancement. It's not a fluid sensitive. It's a post contrast image where you see not seeing any enhancement. There's no collection. Also, you correctly mentioned on the stir images, you see this lesion within the talus, dome of the talus. This is nothing. This is an osteochondral injury.
Okay.
You remember that there is various forms of imaging appearance. So you can see a thin sliver of fluid, what you see typically in an osteochondral defect. In children, you see the osteochondral defect you'll see a thin sliver of fluid. But here you're seeing the dome of the talus, and you're seeing T2 hyperintensity. So this is osteochondral injury. If you see the T1 weighted images, you again see this hypointense area and the dome of the talus, which is seen as a defect in the X-ray, a lucent area. So this is an osteochondral injury to the talus, and the bony fragment has not completely detached. In which case you would see a rim of fluid on the stir images. You'll see a hypointense area, but you'll see a rim of fluid which you're not seeing, but you're seeing this. So this is osteochondral injury to the talus, okay? And also soft tissue ulceration. So you did well in this case. This case is quite a straightforward case. So the patient has a prior history of gallstone, and you see the dilated bowel loops, the small bowel loops which are dilated, and the gallbladder gallstone which is seen in the distal ileum, and the loops after which is collapsed. So they just told you that there is inguinal hernia that is just to divert the case, but the inguinal hernia is not the one which is causing obstruction. It's the gallstone over here in the terminal ileum, in the distal ileum, which is causing the obstruction. And also you very well mentioned that you saw the gallbladder, and you mentioned that there is some subtle focus of air in the gallbladder, which is suggestive of a duodenal fistula. So this is a case of a gallstone ileus.
Okay.
And in the next case, initially, it is very difficult. These lesions are quite difficult, and you didn't see it, but you did very well in this case. You followed the protocol. You seeing there is a lesion in the liver. You see this lesion?
Yes.
So there's a well-defined lesion in segment 4 of the liver. With you correctly mentioned, there is a central hyperintense scar. So a well-defined lesion with a central hyperintense scar could give the differential of FNH and a fibrolamellar HCC. So these are the main differentials, or a hepatocellular carcinoma can also be considered. So what I was expecting in this case is you would they come and ask you what you do next. You have to mention that you will do a hepatobiliary specific contrast, something like a Eovist or a Primovist, gadozectic acid. These are hepatobiliary specific contrast agents. So you need to say that we did a regular contrast and it was not confirmatory. So we went ahead and did a hepatobiliary contrast, specific contrast agent. And this is the hepatobiliary specific contrast agent. And what you see is, you're seeing the lesion, and the entire lesion is showing enhancement. And also the central scar is not enhancing. So that is a very typical, you see the lesion is enhancing like the liver parenchyma, which is suggestive of a hepatocyte within the lesion. So this is confirmatory of an FNH with a central non-enhancing scar. So the way is to differentiate an FNH from HCC, from fibrolamellar type of HCC, is that fibrolamellar HCCs will be more, you can make them out more distinct from the liver parenchyma. They will be seen more distinctly from the liver parenchyma, whereas FNH will be blending with the liver parenchyma. And the central scar in FNH will be hyperintense on a T2 weighted image. And when you give hepatosplary contrast agent, the fibrolamellar, most of the times the fibrolamellar carcinomas will not enhance like the liver parenchyma. Whereas in the FNH, in the hepatobiliary phase, you'll see that they're enhancing equal to the liver parenchyma, and the central scar will not enhance.
Okay.
This is in case of a hepatobiliary specific contrast agents. But when you give a regular contrast, then that is a normal gadolinium, the central scar will enhance in case of FNH.
Okay.
So when you see this, it is confirmatory. You don't have to do anything. No follow-up is required. You can tell them that this is confirmatory of an FNH and no follow-up is required. You don't have to follow it up in ultrasound. Okay?
Okay. Thank you, Doctor.
Well, very well done, candidate 2.
Thank you.
Okay, can we have the next candidate
Akash,
now?
just give me a moment. I've got an announcement to make, and candidate 3 should be ready. Just give me a moment.
Sure.
So next week, actually, I'm going to do a to Z series, which is, you remember that on the weekend we just are concluding MSK, and we went through whole of MSK, and we realized that this is the course which we did in 2020, and 2 or 3 recordings we just realized that we don't have them. So I ended up doing a live session for you a few weeks ago. And right now we are doing rapid reporting on this weekend, but there is another one coming which has to be a live session. This will be next Thursday, and these are based on chapters of MSK, textbooks. So reticular system, hemopoietic disorders, endocrine, and metabolic. Something which is very, very important for the exam. And the current generation of radiologists, you don't see these cases. These will be mostly plain films. So do not miss it. I'm going to do it live next Thursday. Otherwise, you would have seen it on a weekend. So that is what I wanted to announce. Akash, once again, over to you.
Thank you, Dr. Khan. So let's just go back to the main case series. Do we have the next candidate with us?
Hello, Dr. Akash. Can you hear me well?
Yeah, I can hear you. You can take this case.
Okay.
Yeah, you can ask for control.
Okay. I have already requested.
Yeah. Just check if you are able to scroll. Candidate 3.
It's a bit slow, but I can.
Okay.
Yeah.
Sure, go ahead.
So I'm provided with the CT abdomen without contrast, axial images of an adult patient.
He's come with history of left-sided loin pain.
Who has the history of left-sided loin pain. I am looking through the images thoroughly. I can see some high density metallic-like densities in the lower abdomen. And can scrolling through the images. It's quite jumpy. And the area of the just posterior to the pancreatic area and anterior to the left para-aortic area, I could appreciate some soft tissue density with ill-defined margins. And I'm looking through the adrenal gland on the same side. So I cannot appreciate. I will just scroll a little bit up. Just and there are few areas of calcifications in the upper part, and this scan is a bit jumpy. So I cannot clearly appreciate the left adrenal gland. So, and the right adrenal gland is clearly outlined. So I'm suspecting this is an adrenal lesion. So I would correlate with the history of any previous trauma or any, and further I would take with the post-contrast images, post-contrast study for this patient to confirm if this is an enhancing lesion.
There is no trauma, just left loin pain. You can let me just show you the post contrast.
Yeah.
Yeah.
Yeah. So I'm scrolling through the post-contrast images. So this is an enhancing lesion, the suprarenal area, which appears inseparable from the wall of the stomach, and the body of pancreas. I can see it is closely attached, but looks fat planes are clearly appreciated. So, and it is encasing the splenic artery, and so I would correlate again with the history of the patient. If the patient has any history of hypertension or any thing, so I would keep the differentials here, like the pheochromocytoma or paraganglioma here, and the scan is right. And less likely the metastatic lesion or the carcinoma of the adrenal gland. And I would thoroughly go through the whole scan to see if there is any other site of the disease is there, which I cannot barely appreciate. And these are the surgical, these are the clips, though I don't know if this patient has the history of surgery. And apart from this, there is some fixation of the spine. So I would see through the bone windows of the same patient if there is any like suspicious lesion or any fracture, or to see any osseous lesions.
Okay, so what would
So,
you like to do next? What are your top differentials? Could you summarize?
Yeah, so my top differentials are this could be a few chromocytoma, because this is homogeneously enhancing, and less likely this could be a metastatic lesion, but again, the patient has the history of patient, I could see the clips and some fixation of the spine, so I would confirm if there is any bony lesion. So this could be a metastatic lesion. So I would correlate with the history, and if there is any previous surgery done, and inform my findings to the referring team, and further advise PET-CT if they are suspecting some primary lesion or primary malignancy.
Okay, yeah, this was referred to the GIMDT, and we'll just they did an MRI. So let me just show you the MRI. Yeah.
So I am scrolling through the MR post-contrast arterial phase images, and the arterial phase.
You're not able to. Okay, let me just.
Yeah, can you please scroll for me?
Yeah, 1 second. Yeah.
Yeah, so this is photovenous phase of the.
You want me to scroll?
Yeah, just can you please hold here? This actually the this is photovenous phase, and where I can see this is again enhancing with central sort of necrosis. So this looks suspicious for any malignancy, though this could be a primary or metastatic lesion. So I would retract my previous diagnosis and consider it a bit, because this is quite appearance of infiltrative lesion encasing the vessels as well. And few chromocytoma are more likely rounded with homogeneous enhancement. And I don't know, this I can appreciate this renal lesion. I would confirm if this is a simple cyst, or I would correlate with the T2 images if this is a simple cyst or
Yeah, let me
with
just.
an enhancement.
Yeah, let me show you the T2 images. Yeah, these are T2.
So in T2, this is not a fluid signal lesion. And I would just correlate with the T1 without contrast images if this.
Let me show you the T1 non-contrast. Yeah, this is a type of T1 lesion, T1 images here.
Yeah,
These
so
are
this.
post-phase images, but you can see it these.
Yeah, in outphase images, it is still T1 high, so not suppressing. So this could be hemorrhagic like cyst, or with if this component is not enhancing, I can, if I can see the post contrast images again.
Okay.
So, but till now it's like a hemorrhagic cyst.
Yeah. You want to? Can you scroll?
Yeah. So this does not actually demonstrate post contrast enhancement, the central focus, but the peripheral is showing some enhancement, but or underlying the cortex is well preserved. Actually, this.
Okay, so what could you summarize the case? What
So
are top differentials for the lesions?
So this the renal lesion is actually a hemorrhagic lesion with some enhancement. So this is not typical RCC, but this adrenal lesion is quite suspicious. I would still consider it a malignant. So this could be a primary or secondary from other site of lesion. So in case I would advise the PET CT if there is any other focus of disease.
Okay. Any differentials for the adrenal lesion? You said pheochromocytoma and metastasis. Anything else?
And this primary lesion could be there, but less likely the adrenal myelolipoma or lipoma because I couldn't see the fat density there.
Okay, let's go to the next case.
Okay.
Yeah. So this is a
So
case.
this
Yeah.
so this is a barium swallow spot image lateral view.
It's not a spot. It's not a spot. You can scroll through it.
Okay. Okay.
Okay, you want me to scroll?
Yeah. Can you please scroll for me? Yeah. Thank you.
So these are the, yeah.
Yeah. So this uh, contrast is seen through the esophagus and it's outlining the esophagus well. Anterior wall appears intact, but on the posterior uh, mid-cervical part, I can see some irregularity of the wall, uh, which becomes, yeah. And I would correlate with the AP images of the patient.
Unfortunately, we could not take AP. The patient was, I mean, he was having too much of difficulty, so
Mhm.
could not do AP.
So yeah, so this irregularity could be due to the osteophytes of
We had
the
to stop the
spine.
procedure.
So okay, all right. So this irregularity, I am still looking through the irregularity well. So this there are anterior osteophytes also which are causing indentation, but at the same time I can see there is some dilatation of the esophagus. So I don't know if the distal images are available to see for comparison or not.
Okay, so we
And
just,
there
yeah, continue.
and there is contrast pooling at the hypopharyngeal area also. So I cannot see in the even the later images the contrast is not going into the esophagus well. So I don't know. I would correlate with the history of the patient. I don't know what was the history. Sorry.
Yeah, so the patient had difficulty in swallowing. Obviously, for most of the bariums, they come with that history itself.
Okay. This irregularity is in the mid esophagus is looks little suspicious, or I would take the findings with the CT of the patient and see if there is any suspicious lesion is there or not.
Okay, let's go to the CT. Yeah, yeah.
Yeah. So in the
Are you
CT,
able to scroll?
uh, uh, I can try just.
Okay, 1 second. This issues. I think it's gone to another patient CT. Just let me
Yeah, sure.
let me go back 1 second.
I'm not sure I understand.
Okay. Okay, so what is your differentials in this, you said?
So
Yeah.
yeah, this irregularity is quite suspicious for malignancy, and other possibility could be this and chronic ulcerations due to reflux, or there could be some other possibility of any candidiasis or something related, and that. But
Okay, we'll go
again,
to
I
the
would.
next case. We'll go to
Okay.
the next case. The CT is not available. This patient's, I don't know, it's not loading.
Okay.
You can start with this one.
Yeah.
Let me just put the case. Yeah, you can go ahead and you can take these. Yeah.
So I am provided with the MRI, abdomen, T2 fat set images. As I'm scrolling through, I can see T2 high intense lesion in the area of right hepatic lobe with and at the same time I can see T2 hyperintense lesion in one lower thoracic or lower thoracic vertebrae. And at the same time, in the region of the right chest wall or breast, there is again fluid signal intensity lesion. You know, if the patient has any history of surgery, or I would correlate the findings of the history of any surgery.
Would you like to see anything, any other image?
Yeah. So I can see, I would like to see the T1 without and post contrast images.
Okay.
Yeah, so this and this appears T2 T1 low intense lesion with internal septi, and besides there are some T1 hyperintense hyperintense foci in the region of the right chest wall, and at the same time I'm looking for the same lesion seen in the vertebra. I can barely appreciate the same T2 lesion in the vertebra. Can I see the post-contrast images for the same patient?
Okay.
Yeah, so the right lobe lesion does not demonstrate any post-contrast enhancement. However, this vertebral lesion is showing some enhancement, and at the same time, in the right breast, right chest, there is some patchy enhancement also. So I would be very because this liver lesion doesn't look suspicious. This could be hydatid cyst, and at the same time, I would correlate if there is any history of surgery in the right chest or breast, and which has resulted into this fluid pocket. But I'm suspecting this vertebral lesion to be some metastatic focus, and I would again see the whole spine imaging to confirm if this is a solitary lesion or any other lesion is present apart from this. And at the same time, there is another which hyperintense lesion in the left lobe of liver, and
Okay, we also have a CT in this patient.
yeah.
Let me show you. What is your diagnosis for the liver lesion you mentioned?
So this could be head and below the liver. I could also appreciate one. I don't know if this is a part. Yeah, this is gallbladder. So this could be a hydatid cyst in the liver with two lesions. This if this and left lobe lesion has a similar appearance on the T2. I think I overlooked this lesion. So this could be hydatid cyst, and this the vertebral lesion needs further imaging or further confirmation.
Yeah, go ahead.
Yeah, so this has a calcified wall around the lesion. So this confirms my findings that this is more likely a hydatid cyst with a similar lesion in the left lobe. And just see the images completely to see if there is any other focus of disease or something. So can I see the bone window images for the same patient?
Yeah, you can go ahead. You can just 1 second. Let me just put it on bone
Oh,
window.
yeah. Thank you.
Yeah.
Yeah, I'm scrolling through the bone window images. The covered images in the Excel images, I cannot appreciate the lesion, but again, I would see through the upper sections. The lesion which I was suspecting in the MR images, I'm looking for that. Can I see? Yeah. So this lesion has lytic lesion with some sclerotic margins. So this is again suspicious. I would correlate with the sagittal images, but even in this appearance, I am suspecting this to be a metastatic, and in the breast, if there is already any history of surgery or any previous malignancy, so this confirms my findings. So I would to communicate my findings to the primary team, and this correlate with the previous imaging if available.
Okay. Let me take over.
Yeah.
So the first case which you were shown was this one.
Yeah.
So yeah, so this is a plain KUB. The patient came with the history of loin pain. So we went ahead and did KUB. It's a difficult case. There is a lesion. You picked it up. You mentioned initially that there, I mean, after this, on the second look, you picked up there is a lesion and centered in the adrenal region. The lesion is abutting the left crus of the diaphragm. Also, you can see that the lesion with the fat planes with the pancreas is not well made out. The adrenal gland is not separately seen. What you didn't pick up is there is a lesion here. You picked it up later in the MRI, but there is a lesion over here. You see this lesion?
Yeah,
I
can see.
It is fat attenuating. If you had picked it up on the CT, you would have known that the lesion is almost completely fat attenuating. You see this lesion, which is fat attenuating lesion in the kidney. Then we went ahead and we did a contrast study. And in the contrast, we are seeing the same, we are seeing this big lesion heterogeneously enhancing. The fat planes in the groove with the pancreas is lost. There is also averting the left crus of the diaphragm. What you're seeing, you mentioned that there is some vascular compression, but you need to mention which the splenic vein. The splenic vein is not visualized in this region. So we're not seeing the splenic vein. Also, you see there is some amount of collateralization over here. You're seeing all this. These are collaterals. So you have to mention there are multiple collaterals which are seen. The splenic vein is not visualized. And then we went ahead and did an MRI for this patient. On the MRI, this lesion, you correctly picked it up that it is enhancing, but you see that we go to the T1 weighted images. You see it is hyper intense on T1. Okay. We go to the fat suppressed images, and you're seeing that there is fat suppression with some enhancement in the region. There's central fat suppression. There is some peripheral enhancement. So this is a very typical appearance for angiomyolipoma. Fat attenuating lesion with blood enhancing components. It's an angiomyolipoma. Other than that, you see this lesion. This lesion is again, as you saw in the CT, it is encasing the splenic vein. It is centered in the adrenal and the pancreatic groove. So the differentials for this kind of a lesion, it kind of pheochromocytoma, unlikely. It should show much higher enhancement. And the patient also did not have any history of raised hypertension. So the differentials, yeah, we thought it could be a malignancy. But the other differential which you need to keep in mind is IgG4 related disease. And that's what it was. We did a biopsy of this lesion and it turned out to be IgG4 related disease. So always keep that in mind, that can have a unusual appearance. It can look aggressive, and you should keep that in mind.
All right.
Yeah. So this case, what happened was we did a barium swallow, and what you're seeing here is you're seeing a line of contrast. You didn't mention this. Do you see this? Candidate number 3. So that is nothing but aspiration. So the patient had a narrowing in the esophagus. Patient had difficulty in swallowing. We gave contrast, and patient aspirated. So that's why we had to stop the procedure. We could not do it, but you had to mention that you see the contrast going into the trachea, and you see that going downwards. So that's nothing but aspiration. And this is the only AP image what we could obtain. Unfortunately, the CT is not loading for some reason, but the patient had a esophageal mass over here, somewhere on the upper thoracic region, which was causing obstruction, and he aspirated. Okay. We go to the next case. The next case is this one. Yeah, so I showed you the MRI first. It can look very confusing on the MRI, but these are very typical appearance. You see a lesion in the liver. It's hypoattenuating. It's not enhancing. You see peripheral rim of calcification. You're seeing multiple septa, like daughter cysts kind of appearance within the lesion, multiple rounded appearances within the lesion. There is another lesion over here, which is much less like that lesion, but it is also still, you can make out there is some density within the lesion and it's not enhancing. We went ahead and did an MR for this just to look for any solid component or enhancements. And in the MRI, you see that again, you see this lesion. It's predominantly on the T2 weighted images. Yeah, it's predominantly cystic. Again, here you're seeing another lesion, which is again cystic appearing. There is some incidental breast lesion. The bony lesion which you mentioned is there. Definitely it needs further evaluation. The patient is not a known case of any cancer, but you need to do, as you correctly mentioned, you need to do a detailed spine. You have to mention that in your report that you would do a detailed spine evaluation for this lesion, and also an ultrasound evaluation for the breast lesion. So these two lesions on the contrast study, this is the post-contrast study, and you're seeing that there's no typical enhancement. The lesion is just showing some minimal peripheral enhancement, no internal enhancement. Here also there is no enhancement, and there are also some septa within the lesion. This appearance is very typical for a hydatid cyst. So there are multiple hydatid cysts, and you need to mention that you need to further evaluate the breast nodule, which is seen over here on the T2 weighted images, and also the bone lesion. So overall, well done.
Thank you, Dr. Akash.
Yeah. Let's, can we go to the next candidate? Candidate number 4. Are you with us? Candidate number 4.
Just 1 second. I think candidate 4 is candidate 4. You are a co-host, and if you can please speak.
Yes, sir.
Okay, candidate 4 is with you, Akash. Over to you.
Thank you, Dr. Khan. Candidate number 4, can you ask for control? We'll go to the next case. Yeah. So this is your next case. Can you ask for control?
Yes, sir. I'm searching for the control, but I can't see such option.
Could any of the other candidates unmute and please help candidate number 4 how to ask for control?
Candidate 3, are you with us?
I think there's a line up there saying Dr. Akash screen. Just there's a 3 dot there. Press on that one. There's an option for request remote control.
Yes, okay.
Press on that 3 dot thingy.
Yes, I have pressed on 3 dots,
Okay.
and I still not seeing. I'm still not seeing the mouse option or control option.
Do you want me to scroll?
Sir, can you give me the mouse, or it's not possible to do such?
Okay, maybe it is, I think the previous stop remote control. Yeah, the previous candidate. Now can you just check over here?
See again. No, it's not. It's not available. No, not here. Not in the 3 dots. Not in the view
Akash,
option.
I think you scroll for her.
Okay, I can now control. Yes.
Yeah. Go ahead.
Okay, that's good.
Okay. I'm presented there with MR of the knee, axial images, stir sequence. I will scroll through the image and then comment on the finding. I see that there is a joint effusion with lateral displacement of the patella, and there is abnormal signal implicating the medial aspect of the patellar facet, most likely to be osteomalacia or osteochondral lesion. Also, I see that there is bone marrow edema of the medial condyle. I can't see any patelloreticular injury. Can I see the other sequences?
Which sequence do you want to see?
I want to see the proton density surgical and if there is
Yeah, just
a
let
coronal
me
T1.
just 1 second. Let me show you. Yeah, you can scroll.
Mhm. Now I'm presented with a surgical view. I can see any lateral meniscal injury. Or PCL is intact. The ACL is second and show abnormal signal like and possibly to be torn. Now I'm checking for the medial meniscus. The medial meniscus is intact. I see that there is surrounding edema of the surrounding muscle. Now I want to see the coronal images for assessment of the medial
Yeah, just 1
collateral
second.
and lateral.
Leave the control 1 second. I'll put it. Yeah.
Okay. I'm checking for the medial collateral and lateral collateral ligament. I see that there is mild signal around the medial collateral ligament, maybe representing at least grade 2 tear, sorry, injury. And now I want to see if there is T1 sequences for assessment of any underlying fracture.
Okay. Yeah, 1 second. Just leave control 1 second. So we have this sequence. Yeah, you can scroll through.
Yeah, I can see any hypointense fracture line. So in summary, I'm presented with a case of ACL tear, a medial collateral injury, and lateral patellar dislocation or subluxation. I will convey this finding for the physician and for orthopedic consultation to do arthroscopy and fixation of the ACL tear Also, I can't see any associated posterolateral corner injury.
Okay, let's go to the next case. Yeah. Yeah, you can start scrolling.
I'm presented with the CT abdomen with IV compressed, arterial with arterial phase on. Okay. I will scroll through the images and then comment on findings. Okay. I can't see any obvious abnormalities, so I will go to my checklist. There is no abnormal focal lesion in the liver or the spleen. No abnormality detected in the pancreas. Or the I'm suspecting the left kidney may have some control
You can
bulge here.
ignore that. You can ignore that. Yeah.
Okay. Can see any vascular occlusion?
Okay, this patient has come with history of some swelling on the left side of abdomen. He's feeling some swelling on the left side of the abdomen.
Okay, I see that there is
The patient, listen to the history. The patient is feeling some lump on the left side of the abdomen. She feels like there is some swelling and she has some discomfort.
this. Okay, I'm now searching at the site of patient complaint.
In the left lower abdomen, she feels some discomfort and swelling.
There's like a small sphygelian hernia right there. Small defect right there with herniation of the omentum. So it may be representing the site of concern or the site of complaint for this patient. I will convey the finding to the physician and ask for a clinical examination of the patient. to see if
Okay.
it's relevant to such site of herniation or no.
Okay, let's go to the next case. Just 1 second. Can you leave the control? What? Yeah.
I'm presented with left knee X-ray frontal view for an adult patient. And I can hardly see that there is like a lesion here at the medial condyle, medial femoral condyle, which seems surrounded by a lucent margin. But can I window through the image or not possible?
Yeah. What I didn't understand. What can you repeat that?
Windowing, doing some windowing, window
Okay,
the
yeah,
image.
yeah, sure. You want me to? Okay. Yeah.
Okay. Also, I see that there is a faint radiolucent lesion on the medial aspect of the internal of the medial femoral epicondyle. It may be representing osteochondral lesion. I will review the history of the patient and convey the finding for the physician and ask for MRI to confirm my findings.
Would you like to look at the lateral view?
Yes, please. Okay, now I'm presented with lateral view. I will go through my checklist. I can't see any bony fracture line or any gross lytic or radiolucent lesion. There is no obliteration of the joint space or soft tissue masses.
Okay,
There is
so you
no.
want an MRI? We'll go to the MRI. Yeah. So which sequence would you like to see first?
Coronal.
Okay. So this is a coronal T2 weighted image.
I'm presented with stir coronal images. And I see that there is an osteochondral confirms the presence of a lesion at the site of attachment of the ACL. Also, I see that there is another lesion corresponding to the area of marginal radiolucency. So can I check for again the site of I want to be sure if it's the attachment of ACL or no. Just I want to see if there is a sagittal image.
Okay, sure.
Now I'm checking. So I suspect like there is a vaginal injury at the site of femoral attachment of the ACL. I will convey this finding for the physician to do orthopedic consultation
Okay.
and for surgical fixation also.
Yeah, okay. We'll go to the next case. Due to lack of time, let me show you one more case and then we'll summarize.
I'm presented with the CT abdomen and the pelvis IV contours. We'll go through the image and then comment on finding. I'm trying to scroll, but there is
Let me see if okay.
I will go through the image and then comment. I think that there is a like fat accumulation around the rectum and the sigmoid, maybe representing lipomatosis, pelvic lipomatosis. Also, I will screen through the other uppercuts, see if there is any abnormality. If there is a specific complaint,
There is no specific complaint for this patient. He just came with right lower abdominal pain and bloating.
specifically at site of patient complaint, and reviewing my checklists. So I can see any abnormality in the liver or the spleen or the pancreas. Okay, I see that there is a mass relatively hypoenhancing corresponding to the tail of the pancreas. Just partially encasing the splenic vein, but the vein is still patent. No gross lymphadenopathy. No hepatic focal lesion. My differential diagnosis would be adenocarcinoma. So I will convey my finding to the physician and ask for CT guided biopsy from the mass. Also for MDT discussion for the surgical excision and chemotherapy.
How do you propose that we would do a biopsy for this mass, a CT guided biopsy?
Or ultrasound, if it's feasible by any of of
But
those
is there,
images.
any window which you see, which like for biopsy, do you see?
In window.
Okay,
Yes.
let me. We went ahead and did an MRI for this patient. Let me just show you the images. Just 1 second. Could you leave control, please? Yeah. Yeah, you can see this image. I'll show you the relevant images. Yeah. Could you scroll and
This is cost contrast sequence, and I can see the mass show peripheral enhancement and central non-enhancing, mostly likely cystic degeneration. Can I know the age of the patient?
the patient is around 55.
So I'm suspecting that it need, but it's not like typical the pancreatic mucinous cystadenoma, and even though it will be pre-malignant, so anyway I will need to take a biopsy from such mass.
Do you want to see any other sequence?
Yes, I want to see that the T1 and T2 to know if cystic or fat containing.
Okay, let me start with the T2. Yeah, this is T2.
Yes, the lesion appear to be cystic, multilocular and contain relatively large cyst. So my differential diagnosis will be changed a little to be maybe like this representing serous cystogenoma because this looks so small.
What did you
However,
mention? What's your differential?
maybe serous cystogenoma, because also it's keeping with the age of the patient as she is an old female.
Okay, let me take
But
one now. Yeah, I'll go to the feedback. So this case, let me go back to the CT. Okay, let me just 1 second. Yeah, so in the CT, you're seeing that there's a cystic lesion. So the patient has some non-specific symptoms, and we did a CT, and there is a cystic lesion in the region of the tail of the pancreas. This is a contrast enhanced CT. You're seeing some thin septations within the lesion. There is no enhancing solid component seen within the lesion. You correctly mentioned all the points. You mentioned that you can do a CT guided biopsy, but I don't think you can do, because you need a window to do a CT guided biopsy, and it's a cystic lesion, so you can't. There is no solid component in this lesion to biopsy to start with, and secondly, there is a bowel and a spleen. All these structures are there, so you won't. There's no clear-cut window to do a CT guided biopsy, even if you had to. So there's a cystic lesion and with some enhancing septa, but no obvious solid component, no pancreatic duct dilatation. It's not infiltrating the surrounding structures. We did a MRI, and on the MRI, it's very bright on T2 weighted images. You're seeing the T2 weighted images. This cystic lesion looks like multilocular, multiple septations, thin-walled cystic lesion, very bubbly appearance. It's in the region of the tail of the pancreas. No obvious solid component on the T2. Now we go to the post-contrast images. Okay, these are the post-contrast images. You see that it's showing some thin peripheral enhancement. You're seeing these enhancing septa within the lesion, but there is no obvious solid component. Based on, this is a little old, 55, but still my first diagnosis for this kind of appearance would be a mucinous cyst adenoma. A mucinous cyst adenoma will show this multilocular cystic appearance, and it's in the region of the tail of the pancreas, which is a very common location. So that would be a serous cyst adenoma would be more in a little more older, maybe around 70, little older, and it would be region of the head of the pancreas, and it won't have this bubbly cystic appearance. It will be usually unilocular. So that is, and there is no communication. The IPMN would be also another differential, but no obvious communication was seen with the duct. So IPMN was not considered in this case. So you did well in this patient. Let me go to the next, the previous patient. Yeah, so this one, you see, this is a patient with history of trauma. This is a AP view of the knee, and you see this lesion over here. There's a lucent line which is surrounding this lesion, so there is a defect over here. So this is a fracture of the medial femoral condyle. So there's a fracture of the medial femoral condyle. The patient had history of trauma. You have to ask for a lateral view, which you didn't. Any AP view always say that I want to look for lateral before you go for higher modalities. On the lateral view, there is nothing much seen, but you need to still ask. There is no joint effusion. You need to mention there is no joint, which you already did. Then we did an MRI. On the MRI, what you see, what was not seen on the X-ray is this contusion on the, let me just go to the coronal stir images, and you're seeing that there is a contusion on the tibia, which was not made out on the X-ray. So there is a fracture of the tibia, and also there is this defect. So this is a MCL avulsion injury. You're seeing some, the contour of the MCL, you see that it's slightly wavy. The wavy contour of the MCL, you see this? There's a wavy contour, and there is some high signal over here, and there's a defect over here. This is an avulsion injury of the medial collateral ligament. Let me go to the previous case. This case is quite a straightforward. Sometimes you get straightforward cases in X-ray, so in FRCR exam. So the patient had a lump, they were suspecting Spigelian hernia. We got an CT done. But the thing you need to know is that you need to look at every aspect of the scan. So always look at the soft tissue, and especially they will try to give you hints that the patient had a lump. So look at the soft tissue structure. So you see there is a Spigelian hernia, small Spigelian hernia, that was the cause of the patient's lump. And also the pain, you can see there is some fat stranding in this region. So there is no, you have to mention that there is no bowel loop which is herniating. There is some fat stranding which could represent inflammatory changes in this region, and a small Spigelian hernia which is seen. Let me go to the previous case. Okay, so this case you did very well. This is a case of lateral patellar dislocation. So you're seeing that this is a very typical defect and high signal intensity in the region of the medial aspect of the patella. Also, the patella retinaculum is having a wavy contour, and you see that there is some high signal intensity, so indicating an injury to the medial patellar retinaculum and medial patellar defect. With the patella position, if you see, is quite displaced. It should be in this trochlear notch, and you see it's displaced. So this is lateral patellar dislocation. There is no significant ACL injury, as you mentioned. You mentioned ACL injury, but that's just some strain in the region of the ACL. But there's no significant, just a ACL strain and this lateral patellar dislocation. And also there is joint effusion. So overall, you did very well, candidate 4. All the best.
So thank you very much. Brilliant session. I'm sure everybody had a good, real mock exam practice. So thank you very much, Akash.
Thank you, Dr. Khan. Thank you for giving me this opportunity.
Yeah. So once again, announcement regarding the next session, which will be next Thursday. I will be covering that. It is going to be A to Z, lymphoproliferative disorders of bone, hematopoietic disorders, lymphoma and thalassemia and multiple myeloma, that kind of stuff. And then endocrine, and after that metabolic, which is very, very important, rickets, scurvy, and hyperparathyroidism and fluorosis, things like that. These are the type of classical plain films which you don't see in your day-to-day practice these days. And they do come in the exam. So don't miss it. We were supposed to present it as a recording on weekends, but we realized we don't have it. This is something which we did in 2020. So I'm going to do it live next Thursday. See you. And Akash, thank you very much once again. And see you on next Thursday, all of you. Thank you.